Welcome, listeners. This is our forthcoming installation for the 20-minute clinic. Myself and Paul.
I think it's the fifth, damn it.
Fifth?
Yeah.
Goodness me. All right. Come on. Somebody keep tabs here.
Okay, I think it's fifth. We've done a few.
We've done a few, and I'm exceptionally grateful. So pleased that we've got Dr. Matt Phillips join us today. So many different hats that you wear. I'm very, very keen to hear some of your insights, some thoughts. Take it away, Dr. Phillips.
Yeah, thanks, Amit. It's great to be here. So I'm Matt Phillips. I am the consultant for sexual health for Cumbria. I am a professor of genitourinary medicine with the University of Central Lancashire, and at the moment I'm the president of the British Association for Sexual Health and HIV. So nice, busy portfolio.
Wow.
That's a lot of hats.
We missed a professor. I do apologise. Professor Matt Phillips.
Apology not accepted.
Oh, God.
Controversy already.
Honestly.
Just,
We were looking for controversy. This is how we start by offending.
You were looking for controversy.
Hey, look.
Yeah.
Matt, just so pleased to have you on board and coming along, because I know so many hats, and I think that there's something really quite powerful about the sight you have over where primary care, medicine, sexual health is heading from your point of view. What's your typical week? Let's start there.
Well, my typical week is built around my clinics, actually, because like any clinician, that's the best bit of the job. So Mondays, Thursdays are my big clinic days, and then the rest of the week is built around there. The time spent this week, I've been looking after my PhD student, just getting him through his bits of paper to progress his research. I have been working with BASH to look at some of the things like the gonorrhea vaccine, which has been rolled out, which is very exciting.
Wow.
And we're due our big national conference next week. So there we'll be launching some new technologies, which is really exciting. And then back to clinic again on Thursday.
It's a hell of a roller coaster, isn't it?
I'm
Amazing.
just thinking, if the students listening, why choose sexual health maybe as part of...
Because I know we definitely, as registrars, we definitely have the opportunity, don't we, to be able to come along from there on. I understand that we've got nursing colleagues there as well, very much. What's the, let's go back to those clinics. What's the typical stuff you normally see?
So the great joy about clinic is seeing someone coming in really worried, because sexual health's got a lot of stigma attached. A lot of the conditions are quite painful and have really obvious physical symptoms. So seeing someone coming in and just settling into clinic, and you're talking to them and helping them relax and really demonstrating to them that there is no stigma, no judgment, it's all about the medicine, that is a real joy of clinic. And our Monday morning clinics in Carlisle are the big walk-in clinics, so no appointment needed. You just turn up and then you see someone to get sorted. And that's a real pleasure of the job. And it's a great place for some of our GP registrars. We have ITP, GP regis. Yeah. We've got 5th Med elective student at the moment.
Wow.
And you can see anything. People turn up with whatever is on their mind, which might be as simple as starting a new relationship. I just want to check there's nothing wrong with me, to I've been living with this concern for 6 months and now I feel really ill, and you find someone who is quite ill and might need to go up to the hospital.
Goodness me. I mean, it's a hell of a spectrum, isn't it?
Massive spectrum of stuff.
From there on, and walk-ins from your point of view. So Mondays are very much kind of a walk-in, and then Thursdays very much more appointment-based?
Thursday's appointment-based, so we've got, for my list, I've got a mix of kind of pre-booked, semi-urgent stuff where people need to get checked, and I've got my very complex clinic on a Thursday for the stuff that really needs a lot of thought, perhaps wider thinking around laboratory, wider testing, complex behavioural interventions.
Okay. All right. I mean, there's a lot of topical stuff out there, isn't there, really? The gonorrhea vaccines, one thing that comes to mind most recently in the news. What are you seeing a lot of? What's troubling you think, from your point of view in clinic?
So we're seeing a lot of syphilis, which is not out of kilter with the rest of the country.
Okay.
However, sometimes in North Cumbria we can think that our illness profiles are different to the rest of the country. They're not. We're seeing rising rates of syphilis, and syphilis that is not recognised when someone goes to other clinical areas. Syphilis has always been called the great pretender. So it can manifest itself in a number of ways. You can have no symptoms at all. You can begin to get tinnitus. You can get abdominal pain. You can get skin rashes. And they all might be syphilis. And we're seeing people who've seen other people who might not have syphilis at the top of their mind. And then they come to us and we get them sorted.
Blimey, isn't it? Because I know when I was remember just learning about things for the exam and whatnot, this was something that was much more of a mystery and almost a pathology from a bygone era almost. So it's fascinating to see it's coming through. Any particular tips while you've got for listeners about things to think about when they might be considering syphilis as such? Or is it just too complicated?
No, nothing's too complicated for anyone. It's just remembering to have it on your list of things that could be in front of you. I think a top tip that I share with a lot of colleagues who aren't in sexual health, which is the majority of colleagues, is that if there's something funny going on for the patient that you can't put your finger on and your first set of thoughts are disproven, you do some checks, some tests, and they're all negative, do think syphilis and do think HIV. Wow. That kind of place where you're thinking about. Now, I've never worked in general practice, but thinking of it like a sieve, you might think, oh, this person has got this going on, they've got a skin rash, they've got this, we'll try this. But that's not improving. And the first tests are normal, kidney tests normal, etc. And then they come back and you might be thinking, oh, I wonder if it's a strange manifestation of thyroid disease. Syphilis does well sat alongside there.
Oh, wow, okay.
I cannot work out what's going on for this person. I think syphilis, I think HIV.
So for all of these things, do you have multiple tests that would then give you that answer? There isn't just like one set test, it's a lot of different tests.
There is just one set test, but you might not do that first of all when someone comes in, unless they say something that really puts your mind to it. I mean, a great story that I've told over and over again, can't identify, but a married couple had gone to a clinic and seen a specialist. And one of the couple said, I think my partner has got syphilis. And the specialist was like, oh, I'm not sure they have. My top tip to everyone is if the partner thinks their partner's got syphilis, do the test.
Okay.
That's a good clue.
Wow.
If they've decided it might be possible.
Fine.
Do the test.
So it kind of reminds me almost, because we learnt this sort of stuff about HIV as well. If there's ever a inkling of it might be, do the test as such. Similar sort of thing, we think?
It's very similar. And with HIV, I think it is so important to bear in mind that we all have an HIV status, but it may not be known to us at any certain point. So a test will always be helpful going forward. It will either say this person doesn't have HIV, in which case, if they've got a sex life that might mean they're still at risk of getting HIV, they can come to our sexual health clinic and we can start them on meds that mean they don't get HIV, called PrEP. And if they do have HIV, they can get onto HIV meds. So either way, that person's going to be a winner from the test.
Okay. It's something to think about there, isn't it, really?
And there's such a vast array of potential things it could be, I guess. So part of your job is investigating which bit it fits into, I suppose, with the symptoms they're telling you. Like a detective sort of thing. I've watched too many episodes of House. Can you tell? Can you tell I watched too many episodes of House? That's what I'm picturing now. You know,
maybe
Hugh Laurie.
Detective Phillips.
Yes, right.
That's good. That's much
Professor
better.
Detective
Quite
Phillips,
like it. Yeah, it's just like that. So when we see someone in clinic, we'll be doing a number of things for them. If they've got symptoms, we'll be trying to work out what's causing those symptoms, but we'll also be doing screening interventions. So even if you've got a symptom of like a skin rash that you think could be one thing, we'll still offer screening for STIs. Where appropriate, we'll offer cervical smears, so that's screening. And depending on ongoing sex life, we'll offer vaccinations like hepatitis A and B, HPV, Mpox, so we do vaccinate for Mpox, and very soon it will be gonorrhea by the end of the summer.
Fascinating, isn't it? It's amazing what's coming around. And I understand there's a wealth of knowledge about contraception and coils as well.
Yeah, we do all of that at the same time. Yeah.
Fascinating resource. No, so, I mean, a real asset to us in primary care, across the wider healthcare system even, really. Let's go back to logistics. So if I was a clinical colleague thinking actually I need to get somebody seen sexual health, what's the best way, what's the preferred way of accessing services?
Oh, that's such a difficult question to answer. I guess
He's a hard question master, isn't he?
it's good. So we still hold the model for sexual health services. It's a model that's actually 100 years old. It started
really?
in 1918, which is the walk-in model that does not require a referral.
Okay.
And requires you not to write back. And that's an important thing to bear in mind. So if you had someone in front of you and you wanted, and it was just straightforward, someone turned up on the list, they've got a urethral discharge, they can just rock up to walk-in clinic, or they can ring our central line for an appointment. Or if you're really invested, you've got extra knowledge about that person, that means a hand-to-hand handover is better, such as someone with learning difficulties or access needs, then it might be better to ring us directly, and we'll sort that out. A letter is fine, but it happens no quicker or slower. But if a practitioner writes to us, we will write back with what's happened, which will be helpful if someone's complicated. Also, the walk-in model doesn't work quite so well if in primary care the patient's been being looked after with a lot of complex needs for a long time, because we don't have access to those records either. So when the person arrives, if you've been seeing them for 6 months and done lots of bits, that's great to have just in a little note so we can push them forward as opposed to going back to the beginning. But essentially it depends on how unwell the patient is, do they have additional needs, and would you like an answer back about the care that's been provided? And then we've got all the pathways in.
A real fantastic asset there. And then just for our listeners, just for anyone who isn't aware, where are those clinics? Because they're spread across the region, aren't they?
Yeah, so our main clinic is Carlisle. We have Workington, we've got Flatwalks Clinic at Whitehaven, we've got Barrow Clinic, Birchwood, and Kendal Clinic is at Kentwood. So we cover the whole patch.
Huge area, isn't it, really? And those are across the week as well.
They are across the week, and there are different opening times. So if someone rings the central number and asks to be seen, it might be that their local clinic doesn't have a slot that time. They'll be offered a slot at another clinic or at their convenience.
So look, I really hope that's helpful for anyone kind of listening in. I've had so much great feedback from patients about the care they get, the input they have from sexual health as well, knowing about how well they can access services, phenomenal. I think pressures across the system, fantastic to know we've got the backup of our sexual health colleagues as well.
So sometimes do they get referred then? Is that how it works? They would they would go directly to you, and then other times they would get
refer on. Yeah, absolutely.
Right,
So these are all options available at our disposal accordingly.
We've also got advice and guidance, and that is popular. So if anyone's got any questions, just email us. But often what we'll be trying to work out in my service is, does the primary care clinician want to look after that patient and wants a bit of input, or do they want us to take over care? So if that's really explicit, that's dead helpful, because we don't mind either way. But sometimes it's right that the primary care clinician keeps hold of a patient and needs a bit of advice about therapy. Sometimes it's right to hand over, but we're easy. Whichever suits.
Really nice to know, actually, because there's almost a sense of, I've got someone here, I'm not 100% sure what this is. I think this is a sexual health issue rather than a urological or gynecology concern primarily. Nice to know we've got those backups to be able to call upon. And advice and guidance is definitely something to think about there as well. I want to just unpick a little bit with your can I say your bash head on?
Is that technical?
Even if I say you can't, you've said it.
We're not editing that out. That's staying in. Yeah.
Thanks, guys. So what's big in sexual health? What is, there's a pond there in itself, but what would you say is the future and the direction of travel for the specialty?
So that's a really interesting question. I'll have to give you the slightly technical answer. So sexual health actually isn't a specialty. That's the name we use so people understand where we're at. The three specialties are genitourinary medicine, which is called by BASH. So that's infections, skin disease, prevention, vaccine programs. Then you have sexual and reproductive health care, which is contraception, menopause, premenstrual syndromes. And then you have HIV. And we kind of, at our front door, we interface locally. From a BASH level, we'd be looking only at the GU medicine stuff. And the big things really are no new HIV acquisitions by 2030, which is a
Wow.
governmental strategy.
Blimey.
We've been working hard on that in Cumbria, and we were one of the first sites nationally when the trial for the drug that prevents people getting HIV was started.
Fantastic.
PrEP,
Yeah,
that
yeah.
is called. So we're working towards that, and that's about getting everyone tested and then supported to either get into treatment or to not catch it by starting on appropriate medications or interventions. Vaccinations really big. The Mpox vaccine, it was called monkeypox during the outbreak. It's called Mpox now. We vaccinate against that. That is important. Gonorrhea vaccine. The one that is just coming over the hill is something called doxy PEP, which is nice shorthand. But essentially, the studies from the States showing that if after sex, particularly in men who have sex with men, if they have a dose of doxycycline within 72 hours, that greatly reduces the incidence of syphilis,
Okay.
chlamydia, and may influence gonorrhea. So we're just waiting to publish those guidelines. So the big word is about prevention.
Yeah.
In sexual and reproductive health care, that's mostly focused around women's health, and that is so important. We have hosted a virtual women's health hub here in North Cumbria. The funding's been difficult from government, and it's not quite in the strategy anymore from government, but there's a great drive on ensuring that women are well supported in their choices. If they're on a contraception and it doesn't suit them, why the hell should they have to put up with that? They need to keep trying different contraceptions and be sorted until they're on one that really suits them. A lot of focus around menopause, keeping women well in that phase of change.
Yeah. I mean, it's hugely topical. Massive thing at the moment, isn't it, really? So, no, absolutely amazing to hear some parallels with what we push for in primary care, aren't we, really? Some of the agendas that we hold, menopause, prevention, there are some definite parallels and allies there as such.
Do you do that as part of your clinics as well then?
Yeah,
Kind
absolutely,
of
yeah.
Information.
So, I mean, colleagues know when we're listening in, we will try our best to make sure prevention is absolute key for a lot of it, particularly when it comes to things like contraception, menopause and symptom control. Much more topical now. Now it's been talked about a lot more.
Yeah, but I guess you did ask for a bit of controversy earlier.
There we go.
Prevention doesn't mean having less sex or having the kind of sex that some people permit. Prevention is about being supported to have the least adverse consequences possible. So to have the vaccines, to have the post-exposure drugs.
Fantastic.
It doesn't mean don't be having sex. BASH and SRH are all about people having good sex, which we know improves people's mental health and well-being.
Fantastic. Well, look,
There's the headline.
There we go. Should we start with that as a headline for
There's
the
the headline.
podcast? Yeah. No, look, you know what? In some ways, you're right. In some ways, why should we be holding individuals back with being scared about what we can and can't do? Absolutely. Quality of life is definitely something that we should be promoting and celebrating. Look, I try my best to kind of wind this down because we've had a bit of a roller coaster through his whole process. Any final words from you, Matt? Just for our primary care colleagues, everyone from trainees at the moment through to seasoned GPs, ACPs, nurses. Any words?
Yeah, actually, I'd just like to say a big thank you because I'm always really proud, and I speak on national and regional stages about how well we do in North Cumbria about sexual health. I do think we've got a system that we can all talk about tweaks to make it better, but actually we do it well and we work together and we get people to the right place. So a huge thank you to everyone in primary care who helps by taking their part in that.
Oh, you know what? That's a hell of a
That's
turnaround,
nice.
isn't it? Fantastic. One last thing, which I'm doing for everyone.
Yeah, I was going to say he's going to do his
my thing. You know,
his
the
thing.
So one question we're asking everyone. Keen to hear your thoughts about what's one thing you think you'd love to see that we could improve to allow you to be a better clinician in the NHS at the moment.
Oh, you mean in general?
Yeah, in general. Yeah, go on. I know it's a big one.
That is a big one. I think oh gosh, that is a big one. Yeah.
That's his question of the week every week.
Killer question.
Scuppers everyone.
What does Detective Phillips say? The one thing he wishes to see for us to be better clinicians, there's something about us just remembering that things are not as we'd want them to be. We'd all want more money, more staff, more access to technology, and we're all united in that. But for me, I have got a particular philosophy about being a servant, and we work in a national health service, and therefore we are servants. And the person in front of us needs to be served. They're no longer a person on the street, because a person on the street shopping, they're someone who's unwell and worried, and it's our work to serve. And if we can keep that in our minds, it removes a bit of the stress and allows us to access that bit in us that makes us really proud in serving someone who is unwell or worried. And if we can capture that a bit more without too much piety, but just remember we are servants, it takes some of the sting out of the bigger things. There's a real great satisfaction and honour in being able to serve someone.
See, that's really refreshing to hear, isn't it, really? Because you're right, because we're actually, the front of our minds is always about money, resources, workforce, but actually bringing it right down to the patient in front of you, and recognising the joint role and your role in this. Oh, I love that. Beautiful.
That's a good way to finish.
That's a beautiful...
think,
Look, Professor, I'll say it again. Professor...
It's detective now to
Changed
you.
it. Yeah, we've changed it.
You can add as many as you want. Look, Prof. Phillips, it's just been so fantastic to have you on. Fantastic window into your working life, into specialties that you lead, and actually some of the things that we've got available to access via primary care. So good to hear. Thank you so much for coming on.
Thanks for having me.